Okay, the inspections, after finishing inspection, you have to start the palpations. Palpation, as we have been traditionally doing for what purposes, while we do the palpations, palpations component include the superficial palpation and the deep palpation. Superficial palpation just we do for any, any pain, tenderness, any trauma, any crepitations, right? As we see in patients with the penetrating injuries causing the air to come into the subcutaneous tissue, causing producing sort of the crepitations. We do the superficial palpation, just taking the observation. कोई टेम्परेचर को ऊपर से देख लिया हमने, कोई हॉट तो नहीं है, कोई कोल्ड कोई पार्ट तो नहीं है, ठीक है, और सुपरफिशियली हमने पेन टेंडरनेस वगैरह देख लिया, दैट्स सुपरफिशियल palpation. And then comes the deep palpation. So while we do the deep palpation in cardiovascular examinations, the utmost point is to localize the apex beat, right? Apex beat and any edit sound, okay, any thill or murmur, parasternal heave, and palpable harsh sounds. That's the part of the palpation. That what you need to check in palpation. Apex beat, any edit sounds, any thill associated with the murmur, any palpable harsh sounds, or parasternal heave. Okay, so you need to check for this part of the cardiovascular examinations. So palpations, as I said, the palpations include the superficial and deep palpation. And deep palpation is done for the purpose to check out the apex beat, any edit sounds, anything associated with the murmur, and parasternal heave, and palpable harsh sounds. Sometimes you have palpable harsh sounds in different conditions. We will be talking in future lectures. Right. So first you do the localization of the beat. You must be knowing about what is the normal localization of the apex beat. What is the normal where the apex beat is located? Sharpest. It's located in the fifth interval spaces. It's in the medial line. Inside of the medial line, the fifth interval. That is normal. Apex beat. Okay. So when you localize, just you need to warm up your hands in order to check out for the palpitations, and you put your area of the soul over the parasternal area and fly fingers into the air and just touch the chest wall like this. Okay, try to palpate the apex beat with your fingertips, because the fingertips are more sensory, more sensory levels and more sensations. That's why you can easily palpate the apex with the help of fingers, right? And if you can't do this, you have to ask the patient on the left hand position. Train the patient on the left hand position. Baba, cover लीजिए कर इधर. Okay, thank you. You must be having thankful attitude with the patient, right? And if you then try to look at the with a single fingertip. Okay, once you localize, then pinpoint it. The other patient to lie straight, and then you count your level. Starting from the second parasternal area, and the third is first, fourth is fifth is sixth is right, and a rough idea about the mid clavicle line. This is the clavicle. This is mid clavicle line. It is running like this. Okay. So once you localize the apex beat, then you have to check it out where it is actually located. With the help of the second parasternal space. We have been learning since second year anatomy, right? Mandibular angle, and the space lies behind beneath the mandibular angle is the second space. And the third is the fourth space. You have to count the spaces, and you have to make a rough estimate about the midfield line, right?
Yes.
So with this help, you can actually localize the head apex part. Okay, the task is not done yet. Once you localize the apex beat, then you have to check the character of the apex beat, right? आपने localize तो कर लिया, उसके बाद apex beat और parameters भी तो आपने देखने हैं. ये तो नहीं आपने localize कर दिया कि हाँ जी बस छठी स्पेस में है, lateralized है, displaced है. Yes, this is done. Then you have to check out for the rest of the parameters of the apex beat, right? You have to check for the character of the apex beat. What is the character? Normal character है, कोई thrusting character है, heaving है, tapping है, कौन सा character है? Because certainly it would help you in making out the diagnosis, right? ये आपको diagnosis में help करेगा, ठीक है? आपने उसको कर लिया तो diagnosis में help करेगा, apex beat को. Okay, ये सर. और साथ में आपने देखने को adjacent sound या कोई murmur या कुछ थिल आपको नहीं होगी, ठीक है? Apex beat कर लिया तो. उसके बाद then you look for the palpable harsh sounds in parasternal heave. Parasternal heave के देखने के लिए दो तरीके होते हैं हमारे कार्डियोलॉजी में. There are the two methods how do you check the palpation heat. And one is that you put your sole of your palm of your hand over the palpation area, and then you check it out whether it's displayed with the each beat or not. ठीक है, ऐसे फिंगर्स आपने एयर में है, आपका ये जो पामर सरफेस है एज है, ये आपने पैरास्टल लोअर पैरास्टल एरिया पे देखी ही होगा। तो ऐसे हर बीट के साथ आपका हार्ट को डिस्प्लेस करेगा हीव में। एक तरीका ये होता है, और फिंगर्स आपके ऊपर एयर में, ये ऐसे नहीं करना, ऐसे करेंगे तो फिर आपका हीव वाला वो आपका जो डिस्प्लेसमेंट वो नहीं है। आपने ये रखे लोअर पैरास्टल एरिया में ऐसे करना है, और आपने देखना है उसको कि मेरा हीव होगी तो start the movement, you will see you will be able displacement of the palm of the hand with the each successive beats. ठीक है, दूसरा तरीका होता है ये ऐसे आपने हाथ रखना और देखना है कि with each beat the hand is displaced because of the underlying contraction. Why this happens? Because why the palpation is produced? Because there is a consequence of the pulmonary hypertension. Right ventricle producing pulmonary hypertension. Right ventricle having huge myocardium. RV is located just beneath the palpation area. It's pushing the intercostal muscles up, and you are producing certain type of the weight. That is actually displacing the palm of the heart. That is the two mechanisms why the palpation is checked. Is that clear? Okay. After that, you have to check for any palpable heart sounds. Palpable heart sounds में क्या होता है कि आपने सिंपल है कि ये आपने जितने सारे 4 आस्कल्टेटरी एरियाज हैं, चारों को आपने पैल्पेट कर लिया, और चारों को आपने क्या किया, देख लिया कोई palpable heart sounds नहीं आ रहे। There are many conditions where sometimes you are able to palpate heart sounds. There are many conditions like you see the patient with a severe pulmonary hypertension, they have the palpable P2, S2 आप P2 pulmonary जो pulmonary part जो component है second heart sound का वो आपको palpate होता है। Sometimes you have like severe mitral stenosis, loud S1 है वो आपको palpate हो रहा है। ठीक है, इसी तरह different conditions हैं, valvular lesions हैं that may produce palpable heart sounds. Normally we do not able to palpate the heart sounds, but in certain pathological conditions you will be palpating the heart sounds with palpations. Okay, right? So this is how you produce the heart sounds on palpation. Okay, so and then you check for the for any associated murmur and similar murmur. You might have studied in third and fourth year if the murmur is associated is of grade 4 or more than 4, then it produces the film. फिल्म करता है 4 से ज़्यादा की ग्रेडिंग हो मर्मर की तो क्या करेगा, फिल्म प्रोड्यूस करेगा। फिल्म जो है वो फिर आप यू कैन कैलकुलेट विद योर पाम ऑफ योर हैंड्स कि आपको नीचे से वाइब्रेशन ऐसा लगता है कि जैसे वाइब्रेशन है, ठीक है, तो उसको हम कहते हैं कि ये फिल्म भी है। हमें आइडिया हो जाता है कि अगर फिल्म मिल रहा है in the aortic area, in the pulmonary area, so you would be thinking about the murmur that may be underlying this film, ठीक है, तो वो हमें उसका आइडिया हो जाता है। Okay, so palpation में apex beats, palpable heart sounds, paraspinal heave, and any film and any associated कोई और sound है जो आपको palpation के ऊपर मिल सकता है, ठीक है। तो is there any question regarding palpation?
Yes, sir. Pericardial rub.
Okay.
Where we check the pericardial rub?
Yes, she's quite right. You may have some clue about the pericardial rub in palpation, but more accurately, it's is done in the oscillatory manuals. So pericardial rub, you can have an oscillation of the pericardial rub, right, rather than the palpation. Yes, you can have some idea about the pericardial rub. You can palpate the pericardial rub, but it's better to look for the pericardial rub in oscillation. You can oscillate the pericardial rub, right? Is that clear? Any other question you have? That's an important part of the cardiovascular examinations because we all know the escalation is the important part because a diagnosis depends upon the proper oscillations. Once you oscillate the proper, with the maneuvers and proper, position of the body, then you'll be able to locate the where the problem lies and what is the problem lies. You have to look at the murmur. You have to look for the heart sounds. You have to look for the murmurs and where it is located, where it's radiated. Because we all know there are two heart sounds. One is the S1 and S2, right? The S1 is produced. Why the S1 is produced? Sharpish. The S1 is produced because of pleural aortic and mitral valves. While the S2 is produced because of the
Pulmonary and pulmonary.
सेमिनल वासा pulmonary aortic valves क्लोजर की वजह से हो रहा है, ओपनिंग की वजह से नहीं हो रहा. No sound is produced by the opening of sun. There are the sounds may be produced, but they are not auscultated. They are not transmitted throughout the precardium. Why? Because they have the less frequency. These are the less frequency sounds that are produced with the opening of the valves, but closure of the valves produces more prominent hard sounds. Okay? They produce more prominent hard sounds. That's why they have auscultated. They have been transmitted to the precardium. Okay, so every sound, whether it's S1 sound or S2 sound, is produced because of the closure of these valves, respective valves. Okay, so before you are able to try to auscultate the murmur, you must be knowing about the normal harsh sounds. जो हम पढ़ते हैं लुप डुप लुप डुप लुप डुप. लुप is produced because of this one, and डुप is produced S2. ओके, इसमें आपने सिंपल ट्रिक रखना है जो हम हमेशा स्टूडेंट्स को हमें अपने टीचर समझाते थे कि अपने हार्ट साउंड्स खुद सुन लिया करें. ट्राई टू ऑस्कुलेट योर ओन हार्ट साउंड्स. सपोजली यू आर नॉर्मल, यू आर हैविंग नो valvular lesion salivary pathology, you must keep it straight on your precardium and try to listen to your own heart sounds. Then you would be able to differentiate which is the S1 and which is the S2 sound, because the difference lies in the time interval. The S2 follows the S1 with a limited time, a certain time, while the S1 follows the S2 with a longer time. ठीक है, देखो लुप डुब आएगा ना, अब जब लुप आएगा तो वो थोड़े ज्यादा इंटरवल के साथ आएगा. समझ आ रही है? लुप डुब, लुप फर्स्ट राउंड आया, सेकंड आया, अब जो लुप आएगा तो थोड़ा सा लंबा आएगा. तो आप इसी अगर मैनुअल्स को, इसी कॉन्सेप्ट को माइंड रखेंगे एंड एक्सेलरेट करेंगे तो यू वुड बी एबल टू डिफरेंशिएट व्हिच इज द S1 sound and which is the S2 sound. That's important in order to characterize, in order to oscillate, in order to precise the murmur. The where it's located, whether it comes with the S1, whether it comes with S2, it follows the S1, it follows the S2, and where it goes. ठीक है ना? ये सारी चीजें आपने इसी से करनी है कि आपको बुनियादी चीज का पता होना चाहिए. बुनियादी चीज क्या है कि आपको साउंड, हर साउंड का पता होना चाहिए कि which one is the S1 and which one is the S2 sound. Okay, are you getting my points? Any confusion you have? ठीक है, लुप डुप लुप. तो जो लुप डुप है उसका जो टाइम है, उससे फिर जो तीसरा लुप आ रहा है, दूसरा लुप आ रहा है लुप डुब के बाद, उसका थोड़ा लंबा टाइम होगा. ठीक है, उसका थोड़ा लंबा, आपको खुद ही पता चलेगा कि ये दो इकट्ठे आए हैं साउंड्स और ये जो तीसरा साउंड आया थोड़ा देर में आया. तो असल में जो S1 है ये है. समझ के आ गई ना? लुप डुब लुप डुब लुप डुब, इस तरह का इंटरवल्स आपको you have to focus on the intervals here, which one is the S1 and which one is the S2 sounds. ठीक है, एक तो ये तरीका है. What is another method? How would you able to determine which is the S1 and S2? That's very important in characterizing the murmur. You need to check for the carotid pulsations, right? Carotid pulsations, because as we learned in the previous thought, the patient S1 is produced because of closure of the mesenteric tracheosphere, right? And the patient S2 is produced because of the closure of the aortic and pulmonary vein. Actually, if you see the cardiac cycle through, and you might have studied some of the cardiac cycles in final year MBBS, the patient's S1 is produced after the closure of the mitral and tracheosphere. Actually, they have closed after the diastole is completed. Once the diastole is completed, there is a filling of the ventricles with the blood. These valves, the mitral and tracheosphere is closed. They produce the S1 sound. Right? Now the ventricles prepare for the systole, they contract, they eject out the blood, and there's the ejection of the blood out of the ventricles. That produces systole. Right? Now, when the systole is finished, there's a closure of the aortic and pulmonary vein, and they constitute the S2 sound. So, if logically speaking, if we see the cardiac cycle through the osculatory phase, then we will be seeing that S2 is happening with the ventricular systole. Okay. When you just palpate the carotid pulsations with your finger, when the carotid you are able to palpate with your finger and you osculate the precardium simultaneously, the sounds that comes with the pulsation is the S2 sound, because it happens with the ventricular system. When the S2 is produced, you are able to osculate the S2 sound, right? So this is two mechanisms how you would be able to determine what is the S1 sound and what is the S2 sound. You need to keep the focus on the intervals and what the pulsation. The sound that comes with the pulsation is the S2 sound. That follows or precedes is the S1 sound. Okay, that's important in part of the clinical diagnosis. Okay. Or moreover, we have the four oscillatory areas. Let's come to the oscillation, part of the cardiovascular examinations.